So we'll get going now. It's another fantastic opportunity to discuss long COVID pathogen reactivation with Dr. Armin Schwarzbach from AONM Labs. He's going to be answering questions that came up from the talk he gave on the 22nd of August about testing and therapeutic options. And he kindly agreed to do that because we did have so many questions that came in. He didn't have a chance to answer them all. I'll just introduce him briefly for anybody who's new. He's a world expert in the field of laboratory medicine and infectious disease, and his unparalleled expertise in testing for tick-borne disease culminated in the creation of his own laboratory in 2015, AONM Labs in Augsburg, Germany. And he has a team of over 30 staff, handpicked, who have processed many hundreds of thousands of samples from patients with vector-borne disease of all kinds and viruses and many other types of infection and markers as well. He deals with practitioners from over 150 countries, and we're very, very delighted to have him here with us again today. Thank you, Armin. Can I just mention that if time, after asking all the questions from last time, there's still a little left, then we will go on to answer questions that are in the chat and the Q&A. So please do put them in, and we'll go on for about an hour today. So Armin, any brief introduction from you, or would you like to go straight into the questions? I know you've just come back from Florida at the big 𝐒 conference there. Was long COVID pathogen reactivation a topic there too?
No, I came back not from 𝐒. 𝐒 will be in Boston in October, in 1 month around that. Long COVID, I was at the collaboration cures, which is very interesting. The second one, biological dentist, 1,000 attendees. We had also the ANP naturopathic doctors, and I talked about cancer and infections and autoimmune disorders in infections, and very interesting because the mouth is also infected, and we have parallels to dental works, what they are doing, detox, whatever. So biological dentists are very, very important. In America, it's a huge number. I don't know, the British situation as an example. In Germany, we have very few of these species.
Okay, thank you. Yeah, absolutely. We don't have as many here in the UK as we would like. Patients do often end up traveling to Germany, Spain, and elsewhere. So I'll just start answering the questions, not in any particular order. So Ines asked, what does the result of CMV IgG antibodies of over 234 AUs per milliliter mean? Now, the reference range is below 6. I checked that. So she's asking, does that mean it's reactivated or latent?
Yes, this is a first difficult question. IgG alone gives you just the information of IgG. We have different immune globulins in our bodies, and for infections, we have 3 important ones, which I want to mention. It's not just IgG. We have also the IgA, and we have the IgM antibody. They have different half-life times. So the IgM is the first antibody in infection, and also reactivations, and in infections which can get chronic or persistent, the IgM antibody. But the IgG means this infection is around, let me say, 2-3 weeks before the infection happened, but it could be also longer before. But how long we cannot say by just an IgG. So we need the complete information. We need the information. IgA test doesn't exist for the CMV, but we have an IgM test in ELISA. And I want also to mention, we have this perfect test with the 𝐕𝐈𝐃𝐈𝐒 antigen, it's named. It's this is an antigen which means a replication, active infection with the cytomegalovirus. I showed in my presentation, I think so, and also in long COVID reactivations. The antibody IgG can mean anything or nothing. The first is a past infection, but I want to see the IgM. If IgM is negative, per definition, it's a past infection in laboratory medicine, nothing else.
Could I just ask, though, there are the LLMDs who, because they've only ever had antibodies to work with, sometimes consider 4 or 5 times the upper reference range of an IgG to be a possible reactivation.
Exactly, Gillian. The first information, what is necessary here, the antibodies. I cannot interpret this. A laboratory cannot, so it's a broad range of a past infection, reactivation, latent, whatever, persistent. We cannot do anything with that. We need the IgM and we need the EBV ELISpot. Additionally to that information, or the cellular, is it active, interferon gamma or not, cellular immune responses, cellular activities, not, I don't get the information. And then you're correct, one antibody titer means no antibody titer in laboratory medicine. We always need to recheck this, the best way in a parallel. So you cannot send just in 3 or 4 weeks a serum, because every measurement of this test system you did has a own characteristic in it. So there's a variation, 20-25% according with laboratories. So we need always to compare a serum match of a new serum, of a new antibody in 2-3 weeks, because there could be movement in IgG, a tighter movement. And then is the question, this is an ELISA. AU means unit per milliliter. This is not a titration. And what we know that if it would double, let me say, or more than double, 100% more, 460, 500, this laboratory doctor like me would interpret this as significant change, which could mean reactivation or a reinfection, also possible. Reinfection or something like that. But the kinetics, this movement of these titers, therefore one serology, one antibody means nothing. It doesn't help you really.
Okay.
Therefore, you need additionally the IgM information and you need the ELISpot at the same point of time if you want to do that way. Or you work just with IgG, where I don't see any sense in it, because we need to compare serum parallel. We need parallel measurements. So you need to keep this serum. Laboratories don't do that. Costs a lot of money to keep that. And then you could say exactly, is there movement 3-fold tighter? This is really estimation, you know, because you could change the batch of the ELISA you buy from test producers. This is an ELISA, and to double it, this could mean that if you do it in 2-3 weeks later on IgG, it's doubling. This could be reinfection or reactivation maybe. But this is not nothing to say about that. IgG means past infection primarily.
Okay, well, I'll go through the other questions about antibodies that I can see here for now, if you don't mind. There's some may replicate a bit what you've just said. Another attendee asked, I've had some labs done in my country that show previous infection for EBV and parvovirus. It's not indicating IgM. Is it still worthwhile getting checked with Armin? So presumably this attendee meant that they had IgG, no IgM, and asks, is it still worthwhile getting checked with Armin labs?
If you go to traditional doctors, they would say, without being laboratory experts, what they learned at universities, IgG without IgM is past infection. It's over, nothing. So, but now we come to the story. For EBV, you need the early antigen now. What they do in the laboratories is the EBNA, EBNA for the IgG, but not the early antigen. Therefore, you need a microplot. You need an immunoarray, it's named the technique. You need the early antigen. So an IgG without IgM could also mean a reactivation for sure. It could mean also reinfection because you don't have the early antigen. Early antigen also in the post-COVID literature is now one sign for reactivation post-long COVID. You remember back to my, sorry?
I was just going to say, for that one needs this very sophisticated immunoarray.
Exactly.
You do for EBV.
Exactly.
I haven't actually seen any other lab do it that extensively.
Oh, no, that's not correct. That's not correct.
Well, I mean, saw... not ones that are used in the UK anyway.
Yeah, but then...
Which is the good thing about yours, is that it does do all of the or at
Yes.
least a lot of the bands.
Yeah, this is not modern medicine, sorry to say. It's laboratory medicine.
Yeah.
And also what you need to do, the 𝐕𝐈𝐃𝐈𝐒, the lytic antigen. Again, not all patients react on early antigen. Some react on the cellular level, on the lytic or lytic antigen. This is very important information. You need an 𝐈𝐒. You always need to check antibodies, Th2 plus cellular immune reactions, Th1. One information without the other, there is nothing. They complement each other. You cannot exclude that. The doctors don't know that. They exclude it. They say it's exclusion. For parvovirus, we have a problem. For parvovirus, we don't have cellular tests, we don't have 𝐈𝐒, and we don't have an IgA test as an example. For local lice infection, we just have this IgM. The only thing which could help in parvovirus, as you mentioned before, or the one of the first question, to do a control check of the titer of the extinction, in this case of the ELISA, is there movement in it or not, to repeat this test with a fresh blood serum, in this case, 2, 3, 4 weeks later. And then you could see, oh, it's maybe this could be a sign, but the doctors don't know that either.
Whether it's going up or down, yes. And then another one here from Scott. What does a high IgG for Coxsackie tell you if the IgA is normal? Does that still warrant potential treatment?
Yeah, this is a good question. What we see nowadays, a lot of IgA antibodies, I would say in 80% of our results now, they have, and if IgA is positive, that's for sure a current or the last 2, 3 weeks, 4 weeks infection ongoing, maybe reactivation, reinfection, persistency, because we need a formal result to say when was it negative, the IgA, when was IgG negative, so we cannot compare that. It's always good to have a result in this, and then you compare it in laboratory medicine. On the other side, we know that very, very high titers, let me say 10,000 could suppress all other antibodies in a few cases. Yeah, it could suppress IgM, it could suppress IgA. So there's such a clone producing such a huge amount of protein. Antibodies are protein or components of this. So components, though, that you have a suppression in very few cases. Or what you could also ask me, there are some patients who could have IgM deficiencies. They cannot produce IgM. The IgA cannot be produced, IgA subclass deficiencies, or they cannot produce IgG. Therefore, again, you need the cellular immune reaction, which is the 𝐈𝐒, which is 20 to 200-fold in general more sensitive than the antibody test, okay? Because this is independent from any subclass deficiency, immune globulin deficiency you have genetically, or you have acquired secondary immune deficiency, IgG1, 3 subclass deficiency, or IgA1 or 2. This is a combination, all is possible. So I would say if you have a suspicion for ongoing infections, reactivations, you need to check IgG, IgA, IgM total in your blood, and then if it's low, you do the subclasses. I don't know if you do it in England. This would be good immunology, and then you know, is it a subclass deficiency or not. And this is also for monitoring, good also for therapies if you want to do IVIG, intravenous.
That's excellent for if you have a suspicion of PANS-PANDAS as well.
Exactly.
Then, you know, where you do use IgG for testing.
But you know, Gillian, this is also restriction for the interpretation of my results. So some patients cannot produce IgG, so I cannot find it in general. If you're the general, if you do a protein electrophoresis, you can see in the gamma globulin peak reduction as an example. Also, the IgA peak is reduced, but this really in detail laboratory medicine.
Yeah, and you need the patient symptoms and background really to make the final decision, don't you? Another one that does again overlap with that, but has an interesting twist to it. Ben asks, are PCR tests preferable to show active viral infections, or will less expensive serology suffice?
PCR, we learned that really. We did 100,000s of PCR in different projects in the laboratories where I was responsible for. PCR can never tell you is a virus active or not, or a pathogen, SARS-CoV-2 or Borrelia. You need to culture it. But we know that cultures are so difficult. For Borrelia, it's nearly impossible. And if it's positive, high contamination risk. If you open one tube and in the aerosol of the other tube of the positive control is a Borrelia, and it's therefore this, what was it named, advanced laboratories with Joe Boroscano failed completely. I visited the laboratory in Philadelphia and got an offer to do this culture. Another laboratory in America is doing it. And I said, no, why are you not opening these tubes? They need to culture it 6-8 weeks because Borrelia is a very slow growing pathogen. You need weeks for that. It's very sensitive to die in the culture. They said, we are not allowed to open the tube so very often because it's dying. Okay, I say, oh, there's a restriction. 6 to 8 weeks, you cannot. And if you remember that time, they needed 2-3 months for culture. Also Bartonella, the same. There's a laboratory, they culture Bartonella, and they say, yeah, you need 3 different cultures. Yeah, why? Because it's so sensitive to culture, or a high risk for contamination, they said to me. So I know that from where I worked for a famous laboratory group in Europe, in the Synlab group. We know that also this contamination risk of the culture is very, very high in these very sensitive cultures, you know. So I said, I don't want to do any culture. Armin, it's now, I think, 6 years, 7 years, 8 years ago. I said, Armin, stay in your field of the antibodies of cellular tests, and there's not a contamination.
Yeah,
so
yeah.
I think that's a safer way for the patient and not irritation, contamination.
Though I think the additional answer to that one would perhaps be, why not use ELISpots? Yeah. I mean,
Yes,
because
absolutely.
he's asking, are PCR tests preferable over serology? But from everything you've just explained, ELISpots are actually the preferable test.
PCR
so, of course, ideal to do both if you can, as you've just explained.
Gillian, it's so difficult. Yeah, you make a test unreliable. You know, no professor from CAP, Clinical American Pathologist, or our German accreditation authorities, virologists, would accredit a test for you, which is contaminated, which is a problem to insensitive. And if you take a little blood, you don't know, is this virus in this little volume of blood? You need to bleed the whole patient, you know. Therefore, some taking 10 tubes, but you don't never know, because but Borrelia is not the typical, as an example, it's more the tissue. And also we know the spike protein, this in the tissue, the virus is not aiming the bloodstream primarily, you know. All of these pathogens are hiding in the macrophages, and they penetrating into brain, joint, whatever. So it's so difficult with this. We never saw any positive in the blood, Bartonella, and if it's positive, there's something wrong with the test system contamination. I'm pretty sure about that.
I remember you saying that. Yeah. Thank you. Well, we'll leave that topic of antibodies for now. Sylvia asked, she had a very low total T cell count done in your lab in 2020. I presume she means the CD3, CD57. What further tests would that direct towards from your list?
Yeah, this is now the next chapter we are opening, or we have opened, with these 3 I's, which I mentioned: the infection plus inflammation plus immune dysfunction. And the CD3 are parts of our cellular, or the main part of our cellular immune system. They represent the Th1 cells. It came from Freddie Mercury, the 80s times, when we started the first testing of the cellular immune system by this flow cytometry, the CD marker, CD3, which means helper cells dominantly. And if you have a reduction, this is to me so surprising, if it's reduced, the CD3 cells, which we know from HIV models, from AIDS patients. We analyzed a lot of these in the 90s, 80s, 90s, 2000s. We did a lot of these. The HIV immunes were massive, and we see it in normal patients. And we are also surprised, also Jack Lambert in Ireland, Christian Perron in this cryptic conference, what they did also was discussed. So it's so low. And that means that these patients are very weak cellular immune system, like an HIV patient. They don't have HIV, but have a really strong immune suppression. Why? Because opportunistic viruses are doing that chronically. So you suffer from herpes. From time to time, the virus survives in your lymphatic system or wherever it is, in macrophage. They inflame you, they do immune dysfunction, and then they lower over the months, years, the CD3 cells. And this is a massive problem. And I would always check these patients for chronic virus infections. They don't have HIV, don't be irritated, but it's not good to have such a low number, for sure.
Including long COVID, presumably.
Including long COVID and these are also susceptible for getting reactivations or opportunistic infections like EBV, CMV. The same problem is the problem of main problem of HIV patients. It's not the HIV virus.
Yeah. Well, just to mention, because you talked about the cluster of differentiation CD, Paul always asks very complex questions and makes fascinating comments as well. He has one here. Have there been any more studies showing the S1 protein causing dysfunction to the pericytes that support the epithelium via CD147? That's a difficult one.
It's a really complicated question. I know, Gillian, you are also working in this parasitic field.
I looked that up because I found it fascinating. And there are indeed further studies, though I don't know which initial one he's referring to there. But it appears that the S protein acting through the cluster of differentiation 147 receptor has a detrimental effect on human cardiac pericytes. And what's particularly worrying about that is that it appears that it can be the S protein itself, rather than needing the virus, that can contribute to cardiovascular disease. So that's independent of viral infection. So we can imagine what else that might suggest. Yeah, but what they're looking for is ways to dampen down that CD147 in order to allow the pericytes to not be affected. So yes, indeed, there do seem to have been further articles. I'll ask one more of Paul's. He said, would you suggest reducing high expression of IL-4 first when in a Th2 dominant response? If not, you may be driving down Th9, a subset of Th2. No, sorry, you may be driven down Th9, a subset of Th2. So in other words, I think, a more general approach to that would be, what do you do if you're in a Th2 dominant response? What's a first move there?
Yeah. Now we come to the
that's a
cytokines.
Question.
First of all, the cytokines are really problematic in the pre-analytics, okay? Normally, you should not send them longer distances because they are low molecules. It needs really frozen material because otherwise you get a false negative result. Okay, that's a very complicated thing. The time and the control check, we offer some of these which are accredited for without not being frozen, but cytokines are so small, so little molecules. The interleukin 4 is for sure one of the cytokines of Th2, but what we also discussed a lot is interleukin 6, interleukin 12, interleukin 1 especially, and the 2. It's what we say now also in German Borreliose Society. Professor Schneider is actively working that every pathogen has a different cytokine profile. Okay, there was a famous Coxiella Bornetti study. It showed that interleukin 2 is the main cytokine for this Coxiella Bornetti, which is also tick-borne, inhalation is possible from sheep if you walk around them. So it's aerogen transmission also in the milk. It can do lymphoma as an example. It's not so, it's tick-borne illness also. We don't have a really good test. We have IgG, IgM for that. Coxella borneti, I was asked in Greece by many doctors, could you not develop an ELISpot? I'm not the ELISpot developer. This is an independent company developing this test. But what you can say, interleukin-4 is one of the cytokines. But what about the other cytokines? And the problematic thing with this pre-analytic phase, I'm critical about that. I think it's more a point of science. I would not bring this interleukin-4 into discussion now to say this, to do this postulation in general. Okay, should not be generalized. Cytokine profiles, Th1, Th2 dysbalance, how to find that out, which test do we have for that? This is a challenge. We don't have really good tests for Th1, Th2 balances. There's no accredited test.
But you do have the CD19 balanced with the CD3, CD57 to show
this different exactly
versus the Th1 balance, don't you? That
exactly.
New.
This is now the point exactly where you were coming to. We have the CD19. CD19 is with again flow cytometry. It's a cluster. CD means cluster of differentiation. It's a perfect flow cytometry, absolutely reproducible. It's such a fantastic method. You would like that. Also, a laboratory doctor like me. So CD markers, CD19 means this is reflecting the CD19. This is the marker, main marker of the Th2 system of the antibodies. Okay, so the CD19 in the cascade of all of the CD markers in the final end is the main marker, as the CD3 is for the Th1 system. It's better to do quantification of this than to work on cytokines. This is because it's absolutely stabilized, no pre-analytical influences. This is a perfect marker, yes.
Okay, thank you. And Robert asked, he's had a swollen lymph node for 90 days now. He asks, is this normal in your patients?
No, this is not normal. If you have swollen lymph nodes, you have a detox problem, your lymphatic flow is blocked, maybe you need a lymphatic drainage. All of these viruses are lymphotropic, we name it. So they live in your lymphatic system, they're replicating there. They can do also, not to worry this patient, non-Hodgkin lymphoma, also described, you know. And what you could do if the lymph node is not going away, you could do a biopsy. And interestingly, we have now one case, we didn't publish that yet, but I know other groups also did this. In this lymph node, we found by culture living SARS-CoV-2 virus, living, not the spike protein. This patient is very, very sick, young patient, is getting now 𝐃𝐈𝐒, statins, stabilizing, getting slowly better. But we have the really problem that this virus seems to can persist and replicate and be active virus. It's not that spike protein as an immunogen. It's really active. And this patient in the lymph nodes in the neck, which didn't go away, so they did a biopsy, and the pathologist, Dr. Stahl, found active. I have the report in my here on my table. So this is a sign for 1.5 years now, swollen lymph nodes.
Goodness.
Yes.
Oh.
Yes, so a biopsy could bring you and then you could do also a culture, you could do PCR for different pathogens, cytomegalovirus, EBV, what is it? And also a histopathologist should check if this could not move into lymphoma.
From the same patient, just curious, if you do nothing and don't treat these over time, by these I think he means the viruses that have perhaps reactivated, do these viruses go back to submission, or do you always have to treat them post-COVID?
Yeah, also what you need to know, the spleen plays a role in this EHS system, it's named. and although the liver. So both are detox, and these patients with swollen lymph node have a detox. So all the poison, all this dirt is still in the lymphatic system. There's a block in it, for some reason, inflammation, infection, replication. And what to say in this? Yes, you should keep an eye on that, and also you could treat this. I would also do detox for the liver, would check the liver enzymes. Also, if that's all fine. What is the also maybe ultrasound of liver and spleen in this lymphatic system? And you could also do a lymph angiography, I think it's named. So yeah, to check if everything is fine. So if it's not going away, but if it's going away, and also the viruses, this is the one to mention, to the lymphotropic situation of this. Not all viruses doing that, not all in the lymphatic system for sure, but some can do that. And if they SARS-CoV-2 spike protein. Also, what to say about viruses? Yes, we have a lot of pathogens in us, good bacteria, bad bacteria. Also, Bartonella can do swollen lymph nodes, to mention that. Bartonella, cat scratch disease, cat scratch illness, Bartonella henselae in this case, also coming and going. So also, it's a bacteria, it's not a virus. Altogether, I think we need to arrange with these pathogens, MRSA, VRSA, we have in noses, 30% of us have multiple resistant Staphylococcus in our noses, not getting sick. But if you work on intensive care, or you have a multi-trauma and you're intensive care patient, you could die by that, because this can spread all around your body, and there's no antibiotic working in this. So there's no chance. So therefore, they checking a lot of patients. If you're carrier, 30% of us are carrier in the nose, in the throat, without knowing of this MRSA. So we carry a lot of these pathogens, viruses in us without ever getting rid of them. So that means we live with a lot of dangerous pathogens. We live with a lot of good pathogens. We live with medium active. So all of this is immune controlled. And the better your immune system is, CD3 cells, CD19 cells, the better your lifestyle is, the stressing factors, the hormonal axis, cortisol, adrenaline, noradrenaline, the better is the situation for sure. And the age plays a role. The older, getting worse with your immune system.
So you really need the full context of the patient, don't you? Suzanne asks, why do you think Coxsackie is so widespread, at least certainly in the UK? Could it be from infected water supply or from medical interventions? Do we have any hypotheses yet on, because I know that you have told us that Coxsackie and other enteroviruses are much more prevalent in the UK than elsewhere. It's not just that everybody comes up positive for those.
Yeah, but not everybody's getting sick. Most infections are in the families, in the restrooms, inhalation, it's high contagious. It's a smear infection like SARS-CoV-2. It's in the stool. It's several days, weeks, you're infectious to others in the family without knowing it, maybe. It's a kindergarten. It's a school time, very common enterovirus like poliomyelitis virus and also the echovirus. And I could nearly cry. My niece was infected with that without knowing that. She fell into coma a few months ago. Yes, with hypertension. All is described, and also in the family, the mother has also. We found it out with the IgA 1 to 100 titer. So and gut problems, diarrhea. So she got it in the kindergarten. She got stressed, and after a while, she fell into coma, and nobody knew. She was nearly dying. Intensive care, but she survived, and she got a hypertension 200 to 100 by this virus. You cannot imagine that. I'm pretty sure. Also, echovirus, double infection in her. But now we have it under control. She got anti-hypertensive remedies. Now she's fine. So I have a close contact with my sister about that, and we give now also remedies against the virus, and she's improving, but still need to be careful. It's still active 1 to 100 titer IgA. Gut is inflamed for sure. Also today I spoke with a younger woman, a soccer nearly professional. She got vaccination, nothing against vaccinations, but she had 2 years she is suffering now from obstipation. She cannot produce stool 3 weeks, and she has
constipation.
3 weeks, and now
I
they
didn't.
didn't find any reason for that, and now they want to do surgery and remove her colon completely in a clinic in Hamburg. I was so shocked. I said, no, please stop. You have an ecovarius infection, which is a gut infection. Nobody checked this, and now hopefully we could bring this stool outside. Her nutrition is not good, eating meat, pork, very bad, not drinking enough, obstipation. Nobody's caring for that, you know. So the gut is 80% of immunity. She has now a fatigue. You cannot imagine, 90% fatigue. She's a soccer professional and playing not national team in Germany, you know. She's very successful in the first division or so. She was, and 2 years she cannot do anything. She's 50% just working. She's from one of my friend's daughter. She's 22 years now. After first vaccination, 8 weeks later on, 2 years ago. I don't know which company was the vaccination was, but just to mention that case, that's reality. It's simply reality. It's not a nonsense. It's happening around me. It's not long COVID. Ask her, did you have COVID? No vaccination, no COVID.
One of our listeners is asking, do you think she'll recover?
Oh, yeah, I said to her, if you do now the surgery in Hamburg in November, it's planned. I said to her, keep this surgery appointment because we don't know. We do know everything to avoid this. Let's see. But I want to give her hope. I said, okay, 3-4 liters water without gas, no sugar. She's eating sweets, horrible meat, pork. She has lactose intolerance, also fitting to that complexity of leaky gut, obstipation. You know, yeah, I think so. I hope so. I will discuss later on which options we have. Also, I think we will use some herbs, Tacuna, Hotunia for this. Also transfer factors. I said to her, did you do immune support, vitamin C infusions? No, didn't do that. Do you do ozone? No, didn't do that. So I think she has options, you know, therapy options. So I think we have a chance. We will not give that up to surgery. What is surgery? Stress. I said to her, as a surgery, you will not play in the future any soccer again, for sure. Well, remove the colon, remove your complete colon. Can you imagine that?
No. Well, that's a nice segue through to therapy, because we've spent half our time talking about testing. So because you've just mentioned water, Ines says, why the 3 liters of water? Can you expand on what that does?
This has a background. I would not believe that if I would not have that experience with patients and myself also. I use the Cowden protocol or some herbs of them. And when I had a patient, it's some years ago with, I don't know, Tacuna or stevia, what it is from this Cowden herbs from Puner also. The patient didn't improve. I think it was Lyme disease. And then Lee Cowden, I know him very well. We did some workshops together years ago, and he said to me, what is she drinking? I said, why is it important to drink during the herbs? Yeah, he said, oh, okay. I mean, she needs to drink minimum 3 liters water without gas. Healthy water, purified water. I said, okay, well, otherwise the herbs don't work. I said, okay, wow. And then she drank this one and it worked. Yeah. So I was so fascinated about this sentence. I have it so in my brain. And if you also, I didn't know about the biofilms, the coagulopathies, the microclots, and all. We have this from this infection that time. I think it plays also a really important, it's a topic in the circulation of our blood flow to bring these herbs to the peripheral cells, to bring it to the different organ systems. You know, if you don't have a good perfusion, you have cold hands, cold fingers, how can you have good perfusion of this? So therefore you need to drink 3-4 liters, depending on the humidity, how you're sweating, and all of these effects on that, perspiration.
Yeah, thank you. And then Sylvia, because you mentioned ozone just previously, she says, for cleaning your gut, would you recommend intra-intestinal ozone therapy?
Rectal ozone, yes. Rectal, yes.
Rectal ozone.
Yes,
right?
yes.
And
yes. Also, the dentists do it here in the teeth. It's a high resorption there, you know, through the mucosa, very high, very effective. It's more than better than the infusions with it or so.
Val mentions medicinals 9. Have you heard of that at all?
What is it?
In Indian approach to treating
No,
long COVID called medicinals 9.
no. I would be interested in learning about
Yeah.
that for
Well, we'll
sure.
send you some information on that.
Yeah.
Sarah
Need
Michael,
to Google on
is
that.
actually importing that now, and she was given a good talk about that.
We are happy for every information or option. These are all
Yeah,
options. We don't have
definitely.
a wonder pill for
Yeah.
that wonder concept. Yeah.
Yeah. Regarding exercise, last time one of the panelists, Mr. Mitchell or Miss Mitchell, noticed that you suggested exercise for increasing the mitochondria and overall, flexibility of the muscles. But she mentions that exercise is dangerous for ME when patients have post-exertional malaise and they'll
Sure.
crash afterwards. So that's got to be, decided on a very individualized basis, hasn't it?
Absolutely. But the best you can do is fresh air.
Mm-hmm.
And the higher the oxygenation, some therapies are doing that, they bring oxygen, the higher the PO2, its name, the oxygen partial pressure, higher it is, the better it is. Okay, you could also do that, and the lactate and the PCO2, it's reflecting how your metabolic, and this is also traditional medicine. This is school medicine. There's nothing. It's intensive care medicine, also for sports professionals. So also we have some hypo-oxygen therapies now. It's simulating St. Moritz or high where the athletes are training. But what you can do in this, it depends on the individual case. But what is good, it's really a little swimming, maybe a little walking. What you can do, fresh air is the best you can do. And if you live in London, there's not much fresh air, I would say. So if you live in New York City, there's not much fresh air. Whereas, okay, with the parks, but you have a lot of pollution. You have all of these cars around you with this horrible environment. So you need fresh air, and a lot of us are going now. So also my niece now to get a cure at the Northern Sea, so they go to fresh air where it's not so this pollution.
The Baltic, I think that is.
Yeah, Baltic. Yeah.
Helena asks, can the COVID virus affect the liver?
The COVID virus.
Can it affect the liver?
My opinion isn't this sure. If the spike protein is in the macrophages, can go everywhere, to every organ system. Why not?
Yeah, absolutely.
So cytomegalovirus, all of the viruses, EBV, CMV, herpes, they all are hepatotropic, we name it. Yeah. Lymphotropic, hepatotropic.
Yeah. Thomas mentioned the benefits of grape seed extract, because you were talking about how to counter viral infections, and another mention was Bakelin or skullcap, that's super at switching microglial cells from the M1 phenotype to the calming M2 phenotype. Are those also remedies that you would suggest?
Yes, we have also Lyme disease, this approach, and it's an option. Just to mention, I would try it out in 2-3 months. If it doesn't help, it doesn't help. Remove it. Why should you take it longer? No? You should treat different options, or you should need to add something, switch something. Don't stuck in a concept too long. You're too much damage from coagulopathy, inflammation, immune dysfunction if you don't find the right concept therapy option for you. So that's completely different. As I mentioned, if I would do a wonder drug, I would put in artemisia, zinc, selenium, magnesium, whatever, curcumin, vitamin C, high dose, but there's not a wonder pill. We discussed that a lot over the years.
There were 2 very specific questions. Do you have any tips on natural treatment for CMV? And then another attendee asked, do you have any tips on treatment for Bartonella? So those are, of course, 2 rather different infections, aren't they? Yeah,
that's correct. The doctors all say we cannot do anything against viruses. I say always we need to, or said this before crisis, against the EBV and the 𝐶ox, we need to do something. We don't give up in this field. So what I favorize really are the herbs. I'm still absolutely convinced of that. Tacuna, Hutunia, Noni, I also favorize for sure the naturopathy in this case, because you can try it out against the viruses. My perfect choice now, I brought it from USA, 4 times 1 gram L-lysine. I take it every day because of my virus story. It helps me for sure. I'm much better.
Mhm.
My wife is better, so we take L-lysine. Also, my niece is now taking, and she's better. Going a good way. Also, this is an option if you have it in USA.
Licorice and propolis, of course.
Yeah, also propolis. Sure, we take also propolis. Exactly. Licorice, we take a lot of these, but try it out. Try it simply out. It's individual thing. We don't have a wonder propolis concept for all. No.
And specifically for Bartonella, what have you seen that works?
Yeah, Bartonella, if it's Bartonella, I'm still a fan of antibiotics, to be honest. If you have a typical Bartonellosis, I would use the combination of macrolides, azithromycin, clarithromycin, combination rifampin, if it's typically Bartonella, or just alone a Bartonellosis. But if you have a combination with the virus, I would not use the antibiotics. I would go again to the herbs. So we have also herbal protocols for Bartonella. If you use antibiotics, you damage the gut. Don't forget the gut. The microbiome is destroyed for months, years. You cannot repair this so easily. Also the oral microbiome. They had also interesting pills here, Probiora. I learned in America that they also work here in the mouth. You chew them, and they say it starts in the mouth. That's clear. It's not just to take some liquids or some pills for your gut. It's really in the mouth starting for sure. Do something there. This I learned there. So the mouth is also needs to be respected in this. But Bartonella, we have some herbs. I need to inform myself. I'm fan of this. I could mention now, not product marketing, but buy the book from Stephen Puna.
Calendula is one that's
calendula,
and also of course artemisinin.
Artemisinin. Okay, thank you.
Yeah.
You are also in this field active. I know, Gillian. Thank you for your support. I am not a naturopath. Sorry to say that, but I know a little more about that now. Yes, if you have a virus additionally, and I swear every patient which I diagnose with chronic Bartonellosis has a virus infection and maybe parasital infection. So just antibiotics will not resolve the problem completely. You need a different approach because the gut is damaged, I think, with this hard line antibiotic way.
Thank you. I think that probably answered the question here. That was another one. What works best for viral support in your experience? I think you've given a good view of how one has to be a bit differentiated about that and take a slightly different approach, perhaps to Coxsackie as against
but also
viruses.
This is not satisfying me now. The approach alone, I mentioned, we need to diagnose and treat the 3 I's infection we talked about now with these herbs, but we need also to reduce the inflammation. We need also to support the immune system.
Exactly,
it's not just done by taking little herbs. You need to work with your
absolutely right.
nutrition, no noodles, no pasta, no meat. And so, basic nutrition, no sugar, no alcohol, nothing, zero, no sweets, nothing, no chips, no potatoes, a lot of sugar in it. You need to completely change your nutrition if you're sick from that. Also, long COVID patients need to do that. Otherwise, they never will get healthy. So, and the 80% of immunity is in the gut. It's easy. It costs you not so much money. How to support the gut? Also, the immune system, vitamin C, curcumin. We use a lot. We use garlic. We use also, what is it named? The artemisinin. You have different options there. The glutathione, I mentioned L-lysine as a possibility. You have a lot of options there.
What I would like to mention at this juncture is that you've kindly agreed to take part in a roundtable discussion on the 10th of October, same time as usual, 7 o'clock, where we'll have several different therapists taking part as well. And so if anybody listening here would like to prepare their cases or prepare specific questions, that'll be Dr. Schwarzbach, as well as a very prominent naturopath called Zaneta Misho, and Professor Leona Gilbert, who you've heard before, speaking specifically about natural remedies for Borrelia. And then I'll be taking part as well. I've been invited to, and we'll possibly have another speaker as well. So that'll be a very nice round table. on Tuesday, the 10th of October. So, you know, we can cover further questions then. I'm just seeing whether we've covered everything. Yeah, there are a couple of further questions that we could maybe finish with here from the Q&A last time. Do you believe that the COVID virus becomes a persistent virus in humans like EBV and may need to be considered lifelong? Is this in some people or all people?
No, not all people. Not all people have vaccination problems. Not all people have long COVID, for sure. Also, it depend. You all know it depended on the wave 1, the aggressiveness of the virulence of these virus, changing mutations. So, but nevertheless, we have got a lot of damaged patients. But as I mentioned, it can live, it can survive for weeks, months, years, maybe in lymphatic system.
I think the evidence probably isn't in yet. You know, we'll know more as the years pass. But if people continue to do the kinds of surveys that you've just explained and look to see whether it's still present longer than 18 months, then we'll have a lot more evidence, won't we? Both that and the spike protein. And then one more, perhaps to finish with, the question of vowels. Isn't it better to say that long COVID is not a link to opportunistic viruses, but rather that long COVID causes immunosuppression and as a result, reactivation of these viruses?
Yes, this is exactly my model.
Yeah, that's your 3 eyes model, really, isn't it?
Yeah, it's not just my model, you know, it's part from Jack Lambert's work and all the FDA postulations. They if you go into the literature, you will find also this, now that they talk about that, you know. But the opportunistic viruses, I think this is more my work, because Jack Lambert overtook this now in his 2-eye model, which switched to 3, another immune dysfunction. That was my addition to that. We both, he's an HIV specialist. I was also HIV working in the 80s, 90s with the patients. So we know this model, how it works, how the opportunistic CMV, EBV, this is not a new story. So we know how we could handle with it. In some patients, as I mentioned, also you need to use virostatics to keep it under control. If it's still active virus, CMV, 𝐃𝐈𝐒𝐿, it works really. It works perfect. I rescued the life from one HIV patient in the 90s, I remember, with a bleeding colitis, HIV patient, high infectious. HIV, we did a coloscopy, we did biopsy of his colon, we found really the CMV virus. My professor was a professor for liver and gut, so with a hepatitis professor. So, and we found this in the gut, and then I treated him 3 days 𝐃𝐈𝐒. The bleeding was away, the CMV, and this HIV patient recovered perfectly. 3 days. 3 days. We have the valacyclovir now. We have also this acyclovir, the easiest point. We have for EBV the 𝐷𝐿-Immun, it's named the inosine 5-phosphate. It's also one of the options for that. Why should we not try out virostatics if we don't come forward? But they are chemical drugs and have side effects. We need also to control check liver, kidney function. It's not so, you could not buy it easily. I know you can buy acyclovir easily for you in the drugstores, but I don't think it's good to do it without any control check of your organ system, not that you get a side effect.
Now I'm going over to the chat. Just a few questions we might have time for. One is, do you provide testing for people in the US?
Yes, we are CRP accredited, so I'm really proud of that. There are not many laboratories in infectious diseases. I think there's one other laboratory which has the clinical, not the 𝐶LIA is included. So this is the highest quality standard. And everybody who knows me, I want to do the highest quality and not in-house homebrew test where you make everybody positive and say, this is my criteria, this is the other criteria. We need evidence-based laboratory tests, we need standardized tests, we need comparable tests, and this I'm staying for, and the CRP is reflecting that. This is on, in America, the CAP, we have also distributor now, a good guy, it's now, wow, running perfectly.
Yeah, we're in touch with him, so we can help if it's people here who'd like information on that. The question does continue with, and this is presumably for the US, is there any assistance for low-income families who cannot work?
Yes, we have also. Yes, we also did with you together. As you remember, charity cases, patients could apply. We also could do some reductions in some cases. We are not overpriced. Please, I want to give to more patients the chance to recover, because the higher the volume is, the more patient samples I can diagnose, the better I could do the price for the test. That's an easy role. The less samples you get, the overpriced you are. This is in laboratory medicine always the same. I want to do fair prices, and I think we are really cheap in this in comparison with American laboratories in this field.
Yeah. This isn't so much about long COVID, but I'll just read it anyway, because I did, funnily enough, hear about this in a Zoom call that I was in this morning. Dr. Matthew Dryden recently wrote in the Times saying that in some cases, private clinics send tests to overseas laboratories that often, in quotation marks, provide the result they want, a positive result for Lyme. Do you agree? Asks this attendee.
years ago, I went to Portendown, and I know him personally. I know also Tim Brooks personally. So there was unfortunately no forthcome with both of them, although they promised to do something together, not to say make all this nonsense sentence, because to say maybe 30% of my Lyme tests are positive. Lyme is not the main problem in the countries, not at all. It's
I remember
more
once doing an analysis of your tests, and it was only 10% of those who had asked to do that test that were positive.
Completely nonsense, this sentence. This is to make something bad, but the point is, why are they not offering this test or try it out? They can buy it, they can do it, we could compare. That would bring us forward. This is not serious medicine to say these sentences, this political thing. This is not the way I want to work. I don't work. I never work this level. I don't know if Portendown is now accredited or CAP accredited. I don't know that. If they have that, then they have my quality, but I'm sure they don't have CAP accreditation. Just 3 laboratories in Germany or 4 have that.
Yeah. There are some long and complex questions relating to therapy, which we will save for the next time when we have that round table. So we won't dismiss them at all. Please don't worry if they don't get asked today. But Leo asks, is niclosamide a good medication for viruses? I think that's also called Alinia.
Alinia, Alinia is also used. It's an option. Try it 2-3 months. If it helps, it helps. Wonderful, you have found your way. Perfect. If it doesn't help, not too long. Also, maybe to mention, Gillian, you could get 𝐃𝐈𝐒 reactions. Or 𝐃𝐈𝐒 it's better, because 𝐃𝐈𝐒, it's not the medical expression for that. Also in Lyme disease, not 𝐃𝐈𝐒, it's 𝐃𝐈𝐒 reactions. So they have a high viral load and a high load of lipopolysaccharides, and the destruction of these pathogens protein is coming into your bloodstream, and then you have an explosion of that. So some are overreacting from one drop of the herbs, they explode in a 𝐃𝐈𝐒 they cannot tolerate. You would not believe that. So be careful with all of these therapies. Start with a low dosage, so that means they are really powerful and the patients are not crazy, they're not psychotic, they tell you the story and the truth. And maybe you do a diary about that from day to day to know what is your dosage also, or weekly status report or something like that. Yes.
I'll just fit in a few more questions, a couple of, again, slightly complex ones. There is much debate on whether long COVID is persistence of spike protein in monocytes only, or actual virus that may still be able to replicate, much like EBV. Where do you stand on this debate? Or might both be possible?
Exactly. I think it's most both. Why? Because we do a lot of spike protein tests with it's named iSpot, ISPOT test, where we check interleukin 2 for past infection, Th2 versus interferon gamma. And we see, surprisingly, some patients with interferon gamma release, months, weeks. So that means there's still immunogen of the spike protein. And additionally, it's not enough to do the cellular test, the Th1. You need to do IgG, IgA antibodies, spike. We have the test, I mentioned that from Euroimmune. It's Professor Stöcker, very famous guy here in Germany, also very, very good company in all of these infections, and also American-based offering now this test. And this spike protein, we see so high titers, you cannot imagine that. IgG, IgA, overboosted. IgA, why IgA in this? It's past infection, you don't have IgA. And
Yeah.
it's overdriven. So that means there's still local inflammation, maybe local infection with this spike protein, the whole virus.
Relating to 𝐈𝐒, a fascinating question here. Does a positive SARS-CoV-2 𝐈𝐒 suggest replication competent virus?
If the interferon gamma is positive, not if the interleukin 2 is positive. Interleukin 2 past infection, interferon gamma in this 𝐈𝐒 currently active infection. So
okay. That's really important.
it's not a proof.
This
is not a proof piece. These laboratory tests never can prove. Either you culture it, you do biopsy culture with all of these difficulties, the SARS-CoV-2 and
but
the
it's
money.
an indication, isn't it?
It's yeah, exactly. This is what laboratories are doing in all infections. So this is really important to check again back to this IgG/IgA titers. It's a, and if you overbooster, you suppress Th1, and then you get these Th17 pathways with these autoimmune disorders, Hashimoto's. You're on board of this. So and you don't know how many people don't know how high is the titer. Nobody did this during vaccination. I never understood. Never.
Never. Yeah. Well, I'll just ask one more, and then we'll save all the other ones for October the 10th. This is about RANTES, which is a recent test that you've introduced. Can RANTES reflect any other inflammation other than from jawbone infection and retroviruses?
Yes.
And just as follow on from that, are there any plans to introduce an Armin Labs test for thioethers?
Yeah, the RANTES, I really want to leave this test. Why? Because it's so unspecific. And the literature and the reference ranges, if you Google for that, we did a lot of research. It came from the dentist with these NICOs and these cavities to do surgery on them. There we have a cancer, so it's such an unspecific marker, please. I don't trust in this, to be honest. We offered it now, we discuss it today in our meeting of all employees, and I said to myself, okay, I'm not so happy with this. And what was the other marker we should introduce?
Whether you might be introducing a test of thioethers. That's other types of toxins that are exuded in the dental, jawbone area.
Yes, if this test for accredited laboratories with CAP and German accreditation and UCAS, British allowance, yes, it needs to be a CE certified IVD registered test, and I think it will fail there. So we are not allowed in European laws. So I will check this, but if it's not fulfilling that criteria, it costs a lot of money to register and to show evidence based that this test makes sense for positive, negative. It's in Amsterdam, this new IVDR law. We have it for all. Not in England. You have good luck. You can do what you want. Your in-house test still, but in whole European Union, also as an example, phages test will not come through that. So it's over in 2 years if you don't show evidence-based. Many laboratories doing phages test, yes, and we compare the results. I'm not the only laboratory doing my test, so we compare every week, every month. We are forced to do external controls also for CAP accreditation. Otherwise, the test is not reliable, in my opinion.
That's fascinating. I think we need a separate session from you on that. Can I just ask 2 shorty questions? At least I think they're shorties. How is 𝐈𝐒 different from 𝐸LISpot?
It's a 2-color technique. If you're interested, you could go on the website of the company, www.𝐸LISpot.com. You will see the readers, you will see the colors, red, green. Yes, it's a different technique because it's the reader is different. It's a fluorescence assay they use in the end. The 𝐸LISpot is an ELISA technique in the end. Therefore, they named it different. And it's a 2-color. We have different readers also for that in the laboratory, very expensive readers. And they measure these different spots now for longer time, red, green light. You can see there. It's a little different in the modification of this method.
the most important thing is what you, I think, just mentioned earlier, which is that the IL-2 shows that it's on the way out, that the that it's not positive anymore, whereas the
exactly
interferon gamma shows that it's more likely to be still positive.
𝐈𝐒
So you've got a little bit like a sort of lytic and latent in one test.
Exactly. 𝐈𝐒 means interferon gamma release. So this makes sense if you don't know anything in the beginning to spare the money. But if you're treated, as an example, always do the 𝐈𝐒 if you're under treatment. So you can see the switch into from the cellular system away from interferon gamma to interleukin-2. And we also saw that in vaccination with SARS-CoV-2. They switched a lot of papers on that. There's also a company in England doing similar tests, but it's not the same test. It's different.
No, I think having a separate talk with you all about the 𝐿 and the 𝐈𝐒 would be super. So let's organize that for later in the year if there would be interest in that. One last question. I hope it's a shortie. It might not be. What is the most comprehensive way to test for Bartonella?
This is a challenge. I'm not so happy with that. Also with these plots, what they are doing, also with in-house criteria. I'm not also with these cultures. I'm not so happy with that. What I can tell you,
you've got the 𝐿, haven't you?
But it's just for Bartonella henselae. You know, we have also different other subspecies, but we need again a high quality test. It doesn't make sense to do in-house homebrew test because this is not comparable, and you can do your definition like you want. You make a lot of people sick, and they don't have Bartonella with that species. Please, also cross reactions. You need to show it in different laboratories, not just one laboratory in the world, to show Western blot or immunoblot for Bartonella. That doesn't make sense. You know, you need to compare results also for CIP, never fulfilling CIP CAP accreditation, never, also not German accreditation. They will kick you off with a test system. So we need CE again, certified IVD register test. But the best, what means the best test? What we can offer now is we have this TICPLEX ELISA for Bartonella henselae, which is very sensitive. It's a TICPLEX Plus test. And we have also the IFA immune fluorescence, very old technique, IgG, IgM for henselae and Quintana. They all are CE certified IVD register. And we have the 𝐿 for henselae. This also CIP accredited.
So if one can afford all three, then one has a very broad testing.
Yes, you could try also culture. You pay 1,000 or more. Okay, we're not talking about.
But you described the downsides of culture and the other laboratories.
Culture is so difficult. Also the immunoplots, microarrays. It's not everybody can do that. We need to work on that for sure. We need to work on different subspecies also. But you know, the market is not there because it's blocked, as you talked about. Trident.
Things will change. Things are changing.
Hopefully, Hopefully.
Well, thank you so much. That was fascinating as always, and went into a lot of detail. So I hope it was useful for everyone. There are a lot of you know gestures of appreciation. Lots of thanks here. I just wanted to mention that we will be having another webinar on the 26th of September. That's a Tuesday at 7 o'clock with Dr. Robert Verkerk and Melanie Aldridge on their tremendous book, Reset Eating, with a lot of interesting information around that. And then, as previously mentioned, a round table on Tuesday, October the 10th, where we'll have several specialists talking specifically about therapy. So please bring along your case studies and bring along your questions to that. And we'll copy over these extra questions here and post those as well. So Dr. Schwarzbach, thank you so much again. Fantastic. And look forward to seeing you this weekend. Could you just say one word about the Chronic Pathologies Conference of yours?
Yes, I'm so happy seeing Dietrich Klinghardt, a good friend of mine here in Gilching. We have this fantastic Chronic Pathologies Conference initiated from Paul Zedler with his transfer factors. Will be in the national conference. We have over 130 attendees, therapists is our aiming group. That's so fantastic to have this here from, I don't know how many nationalities they are coming. It's 3 days conference with workshops, speakers from Italy, from Belgium, from Germany, from Canada, from England.
It's going to be also translated simultaneously. I mean, you've got a huge team up there, I think, for all these rather complicated, in some cases, very fascinating topics. And what I have found amazing is that it's only €49 if you want to attend virtually for all 3 days. So that's extremely generous, I think, isn't it? And it's chronic pathologies. And then if you put in 2023, it'll immediately come up, won't it?
Exactly. If Gillian is there talking, I'm talking.
Yeah.
That's not all. Also, dentists talking.
Yeah.
We have different species of our colleagues, and not just Dietrich is talking there and doing a workshop. Also, I'm so happy, and we have here in Bavaria nearly Oktoberfest time, so we will have a lot of fun here.
Yeah.
If you're coming here and enjoy Bavaria, and happy seeing you, Gillian, again. Thank you for your work.
Thank you. Well, I look forward to it. I'll be traveling to see you tomorrow. So thank you very much again. And thank you, everybody, for being with us this evening. And I'm delighted at all your questions, and hope to see you again soon. Thank you.
Bye-bye. Thank you.
Bye.